comment because we are a little bit short of time. We'll move to this case presentation. The title of the case presentation has been chosen by Out of Reach Target. Shorouk, please go on with your case.
Okay, hello everyone. I will start with my case, which is Out of Reach Target. It is about 21-year-old male patient presented with bilateral gate C edema increased in the past 3 months. No family history of renal disease with positive consanguinity. In 2014, the patient presented with nephrotic syndrome with normal serum creatinine. The patient underwent renal biopsy, which revealed minimally changed disease. The patient started high-dose steroid for 6 weeks. However, no remission occurred, so the patient had steroid resistance, which is absence of complete remission after 6 weeks of standard therapy of steroid in children. This is the first biopsy in the patient showing glomerular abnormalities, and the diagnosis was minimally changed disease. Patient was maintained on steroid and cyclosporin 3 mg per kilogram per day, and conservative therapy was started, including judicious use of ACE and diuretics. 24-hour urinary protein was between 2 to 3 grams per day, and serum creatinine was 0.9 milligram per deciliter. In 2016, serum creatinine was 1.7 milligram per deciliter. 24-hour urinary protein was 5 grams per day. Cyclosporin level was 165 nanogram per ml, which is slightly above the recommended target in children. So at this point, the patient had CNI resistance and renal impairment. Cyclosporin was stopped and renal biopsy was performed. We needed to exclude causes of acute kidney injury that can occur in a patient with minimally changed disease, including calcineurin inhibitor toxicity, diuretic-induced hypovolemia, acute tubular necrosis due to massive proteinuria, bilateral renal vein thrombosis, infection, and drug reaction, including non-steroidal antibiotic and ACE. The biopsy showed 8 glomeruli per section, 5 of which were near totally sclerotic glomeruli, and only 1 glomerulus was segmentally sclerotic, while 2 glomeruli of the 8 glomeruli were normal. And this is hematoxylin and eosine stained section showing 4 totally sclerotic glomeruli. And this one is Mason trichrome stained section showing 4 totally sclerotic glomeruli. This is another Mason trichrome stained section showing diffuse interstitial fibrosis. And the last one is a blood stained section showing tubular atrophy evidenced by petubular hyalinization and loss of brush border. The patient was maintained on low doses of steroid with cyclosporin dose reduction to 2 milligrams per kilogram per day instead of 3, and MMF was added in a dose of 2 grams per day. Serum creatinine decreased from 1.7 to 1.4 milligrams per deciliter, and proteinuria was between 4 to 6 grams per day. 2 years after, the patient developed hypothyroidism and was maintained on eltroxin 100 micrograms per day. To exclude autoimmune pathology as a cause for renal and thyroid disease, ANA and the anti-double strand and the anti-thyroid microsomal antibodies, anti-thioglobulin antibodies were all done and all were normal. In 2021, the patient presented to us by bilateral gate C edema increased in the past 3 months. By examination, the patient was fully conscious with puffiness in his eye. His vital signs were normal. He had bilateral grade 3 edema lower limb, chest and abdomen examination were normal. However, laboratory investigations showed nephrotic range proteinuria. His 24-hour urinary protein was 9 grams per day. His serum creatinine was 1.4. His serum albumin was 2.4 grams per deciliter. So what is the next step in this patient? First, we checked for hypothyroidism and the cyclosporin level. Cyclosporin level was 132 nanogram per ml, which is in target, and also TSH was in target. So our patient was having a proteinuria of 9 grams despite adequate level of cyclosporin with a duration more than 6 months. So at this level, the patient had CNI and MMF resistance. And the second issue we thought about is rebiopsy. So the patient had another biopsy. The biopsy included 20 glomeruli per section, 4 of which showed hilar and perihilar segmental sclerosis, while 10 of 20 glomeruli were totally sclerotic, and there was focal tubular atrophy and interstitial fibrosis of about 25%. So these are the 3 biopsies of the patient. The first one in 2014 showing minimally changed disease. The second one in 2016 showing 5 of 8 glomeruli were totally sclerotic, diffuse interstitial fibrosis and tubular atrophy. And the last one in 2021 showing 10 of 20 totally sclerotic glomeruli, focal interstitial fibrosis and tubular atrophy. So we were confronted with FSGS case refractory to steroid, CNI, and MMF. So we had 2 questions about this case. What is the value of genetic analysis in this case? And what are other therapeutic options that can be offered to this patient? Thank you.
Shorouk, did the patient ever achieve complete remission and miss this part? At any point since the diagnosis till now, did he ever achieve complete remission?
No, the patient never underwent complete remission. Minimal level of proteinuria was between 2 to 3 grams after start of calcineurin inhibitor. However, it increased again to 9 grams in 2021.
Yes. So the best response, the steroid response was very minimal, and your calcineurin inhibitor helped you a little bit. And now,
yes.
And now you are in this situation.
And now he's receiving MMF with no added benefit, yes.
Dr. Abdullah, would you advise to use rituximab, shots of rituximab in this patient, even without doing genetic study, because we have a problem with genetic study actually. So would you advise to add 2 shots of rituximab to his medication?
I think you went through a lot of immunosuppression here, and you know, if we want to follow the algorithm, rituximab has no evidence as far as effective therapy, but I can tell you that most of us will still give a trial of rituximab for this patient without a lot of hope. So if you look at patients who are steroid resistant, you're looking at the efficacious therapy. We usually give calcineurin inhibitor. The result with the trial with calcineurin inhibitor is around 20 to 30%. For rituximab, as far as complete remission after rituximab for steroid resistance, is around like 10 to 15%. So saying this, we do not have any clinical marker to identify which are the patients that will respond. And since the patient has a full nephrotic syndrome, I will still try a rituximab trial for him. One thing that I worry about, like looking at your patient, that he got a lot of immunosuppression and has an extensive sclerosis. Maybe Shorouk, you are one of the important findings when you presented is that the discrepancy between the creatinine and the kidney biopsy finding. You see, like, this patient has more than 50% global sclerosis, and the interstitial fibrosis and tubular atrophy is quite extensive. So the clinical usually, and that happens most of glomerular disease, is that the clinical findings, meaning creatinine and proteinuria, can fool you into thinking that the patient is way better than the biopsy is. And I would not be surprised if this patient do progress to a point where he will need dialysis very, very quickly. So that will be the thing. You just here, you can just talk with the patient, tell him that you took a lot of immunosuppression. We can give it a try of rituximab, but and it does have a hope of maybe 15-20% of response, but also get the patient prepared to the bad outcome of needing dialysis, because he's not going to progress like this. He's going to just progress very, very quickly towards dialysis, as you can see from his biopsy.
Yes, this discrepancy actually what made us make the third biopsy, because the patient had about 50% of glomerular sclerosis in 2016. However, the creatinine didn't increase. It remained 1.4, and the proteinuria was 9 grams. So that made us go for the third biopsy because of this discrepancy between the clinical progression and the biopsy finding.
Is Dr. Sabri, you were talking? Dr. Sabri.
Yeah, I'm asking about any precaution if this patient passed on stage renal disease and he will ask for renal transplantation. So, would you advise of any genetic testing before renal transplantation? Because I think this patient will have a high rate of recurrence.
Yeah, I mean, genetic testing can reassure the patient, because if you have genetic mutation, you can just tell the patient, you know, it's unlikely to come back. It's not immune related. In this situation, I do not know how much this patient is a primary versus genetic adaptive. It's very hard to tell. Usually primary, you tend to have steroid. So if the patient had responded to steroid and initially and stopped responding later on, maybe I would be more encouraged to say it's primary. There is a good possibility that this patient has an adaptive FSGS or genetic related FSGS, which tend to have lower risk of recurrence. So since he never responded to steroid, I will be just, I would say that it's possible that this patient can undergo biopsy without actually worrying much about recurrence. I mean, it's possible that he recur, but the high recurrence are for these patients who have good response to steroid initially and then stop responding to steroid, where you have permeability factor there, where you have recurrence of 70%. So yeah, genetic testing is important if you have access to it, but it's not imperative specifically in this patient. It can be reassuring if you find any genetic mutation.
Actually, we had a trial to do genetic testing for the patient, but it was not available for us.
We do it for free for our patient here in the United States. Yeah, I'm sorry, that's sorry. Maybe there is delay. I was saying that there is some of these companies where they're trying to get as much data as possible, genetic data, and they are offering it for free for our patient. So it will be interesting to see if on the national level you're willing to give up some of the data to these companies, and they will be able to just offer like more extensive genetic tests. It's very helpful in FSGS.
In view of this, even the last biopsy was an extensive tubular atrophy and fibrosis. If we have accessibility to a cathar gel, I know it is a main line of treatment or have a good response in membranous nephropathy. But if we have an accessibility to a cathar gel, would you advise to use a cathar gel in this patient, or it is too late to start with?
Yeah, the data on Actar gel is all over the place. It's becoming more of belief than actually data-driven. So most of what you see is just case series of Actar gel. So personally, I do not use it. I feel like it's the same as steroid, and it's quite expensive, and the side effects are not small. If you look at the data also, it happened that the most comprehensive trial is just only 12 patients from Columbia University, and the results for Acthar Gel were just in the range of 10 to 15%, just similar to any of these second line. So you have, like we say, a kitchen sink. So you just start throwing stuff on the patient, but at some point you have to realize the side effect. I think your patient has been 2014 till now, or even earlier. So you talk about 8 years of immunosuppression. Acthar Gel is not the easiest immunosuppression to give. So I think just at some point you have to decide to stop after rituximab. I think that's what I would do.
Okay, again, we are a little bit short. Mamdouh, if we have any questions about concerning IMAD, Shorouk presentation from the audience, can present it, please.
Okay, so we have one more question, and you can move to the next presentation. We have a question from Dr. Mohammed Khan. He said, a patient with lymphoma presented with severe proteinuria and nephrotic syndrome. He is asking, is the renal biopsy is required or not? And next question is, will you give a steroid to this patient, or you just treat lymphoma?
Yeah, just you treat the lymphoma. I mean, they're gonna get cyclophosphamide, they're gonna get steroids for their treat of lymphoma. They have these sharp, I think, cyclophosphamide, Hadria, oxaliplatin, and prednisone. So they cannot get tons of steroid, tons of cyclophosphamide. So really, just we do not treat the underlying. So if you have an active lymphoma with nephrotic syndrome, it could be like paraneoplastic, for example, membranous nephropathy. It could be FSGS, minimal change disease. I like to know the histology by doing a kidney biopsy, but really, if the patient is gonna get chemotherapy anyway, you might actually advocate for just treating without biopsying these patients. Histology will not change your management. The pathogenesis is lymphoma related.
Any other questions, Mamdouh?
There is a question actually for Shorouk that they were asking about what was the significance of the third biopsy for this patient. Why did you feel strongly about repeating the biopsy since the patient was not responding since 2016? Were you expecting something different?
Yes, it was strange for us that the serum creatinine was still 1.4 after 6 years of the second biopsy with diffuse interstitial fibrosis, diffuse tubular atrophy. About 50% of the glomeruli were sclerotic. However, the serum creatinine was still the same, and the patient was presented with 9 grams of proteinuria, which could indicate like active lesions or something. So that's why we go for the third one.
And I agree with your approach. I think, I mean, I've seen enough FSGS to know exactly this discrepancy between creatinine and the histology. So I'm not deceived a lot by seeing this. It's a matter of counseling the patient. You have to get them ready for the bad. Do not reassure them, but they can be false reassured by this normal creatinine. We see it in lupus, we see it in FSGS. In glomerular disease, creatinine is a very bad marker. The creatinine will stay in this 1 to 2 range, and then suddenly they just take off and they go to dialysis. So be careful.
Okay, thank you very much, Shorouk. We should move to the next speaker. It will be a case presentation as well. It will be presented by Dr. Mahmoud Naguib.